In this video, we are going to learn about acute kidney injury. Several definitions are there, but for practical purposes, it is sudden increase of creatinine from baseline. It can be broadly classified into pre-renal. Here, kidneys and its structures are intact, but there is decrease in renal blood flow. Intrinsic renal. Here, there is structural damage to kidneys and tubules. And next is obstructive uropathy or post-renal. Here, there is obstruction anywhere in the urinary tract. This patient has diarrhea. This patient has vomiting, and here are the other two patients with septic shock and hemorrhage. In all these patients, the common thing is volume depletion and hypotension, which leads to decreased renal perfusion, which in turn leads to low GFR, which can cause acute kidney injury. This is the mechanism in pre-renal AKI. Here this guy is taking a lot of NSAIDs. If the risk factors of volume depletion are present, then NSAIDs can give AKI. This is a structure of glomerulus with a efferent arteriole and a efferent arteriole. NSAIDs decrease prostaglandins, which can cause constriction of the efferent arteriole, which in turn causes low GFR and AKI. NSAIDs can also give acute interstitial nephritis. This patient is taking ACE inhibitors. ARBs also have similar physiology. It decreases angiotensin II, which in turn causes relaxation of the efferent arteriole, causing low GFR and AKI. Acute tubular necrosis is the most common intrinsic renal cause of AKI. Renal ischemia due to severe pre-renal disease, severe sepsis with hypotension, nephrotoxins like aminoglycosides and IV contrast are the common causes of ATN. How to differentiate between pre-renal AKI and ATN? History is important. History of risk factors causing volume depletion, use of NSAIDs, ACE inhibitors and ARBs are important to diagnose pre-renal AKI. And in ATN, history of use of nephrotoxic agents and severe hypotension. Urine analysis is normal in pre-renal. Hyaline and granular casts are considered normal. In ATN, it shows muddy brown granular and epithelial cell casts and free renal tubular epithelial cells. Urine sodium as shown. Fractional excretion of sodium as shown. And response to fluids is the gold standard to distinguish between pre-renal AKI and ATN. Creatinine improves in pre-renal with fluids. Most of ATNs improve by discontinuing nephrotoxins and stabilizing BP. This patient is found to have pre-renal AKI, but urine sodium is greater than 20. Why is that? In some patients, there will be increased ADH release due to hypovolemia, so there will be less urine output with high sodium concentration. This patient is found to have ATN, but urine sodium is less than 40. Why is that? Here, due to tubular damage, there is decreased water reabsorption, so more urine output dilutes sodium excretion. So urine sodium is not always accurate, but there are problems with FeNO too. This part we know. This we know too. Here in these conditions like cirrhosis and heart failure, it might be less than 1. In conditions where tubules are intact like glomerulonephritis and vasculitis, it is less than 1. In this case, it should be done after diuretics effect is gone. So both FeNO and urine sodium should be used judiciously. Now we discuss obstructive uropathy. Obstructive uropathy gives AKI only if both kidneys are affected. If only one kidney is functional, then unilateral obstruction can cause AKI. Bladder outlet obstruction with BPH, prostate cancer or blood clots, and any tumor causing bladder outlet obstruction can give AKI. Stones and clots in ureter can give AKI. Retroperitoneal fibrosis or cancer causing bilateral ureteral obstruction can give AKI. It is important to recognize obstructive uropathy early as it is reversible and chronic complications can be avoided. ultrasound or CT scan are good studies. Thank you for watching this video.